Hi, this is the first of two recordings focusing on disorders of the digestive tract. So we're going to start off by talking about some common clinical manifestations, and then we're going to follow up with some common disorders of the esophagus, and then some common disorders of the small and large intestines. And in the second recording, we're going to focus on disorders of the stomach as well as peptic ulcer disease. So let's start. One of the first clinical manifestations of gastrointestinal disorders is diarrhea. So what happens is that when undigested and unabsorbed contents enter into the first part of the large intestine, the cecum, it usually takes at least 10 hours for it to make its way through the large intestine. As the contents move along the large intestine, what happens is water is reabsorbed from the lumen of the large intestine into the blood vessels that surround it. And in doing so, the undigested and unabsorbed contents moves from being liquid at this part to semi-liquid until when you get to the sigmoid colon, it becomes solid, right? Diarrhea is when instead of it taking 10 or more hours, the contents in the large intestine move through it very, very quickly. So there's an increase in the frequency of defecation, pooping, and an increase in the amount of fluid and the volume of the fecal matter that emerges from the anus. And because there is a lot of fluid in diarrhea, then it can lead to dehydration as well as electrolyte imbalances. So some reasons for diarrhea is that it might have an osmotic mechanism, in that what happens is with the osmotic mechanism is that there is contents within the colon that basically draw water into it, so that instead of the water leaving the colon, the water stays in the colon. And then what happens is that you have an increase in the fluid content and volume of feces. Secondly, it could be secretory. So in that, what happens is that, again, the sodium absorption from the colon is inhibited, and where sodium goes, water follows. So if there's less sodium being absorbed, then there's also less water being absorbed. And so the water stays in the colon, and then you have an increase in fluid content and volume of fecal matter. The third reason is an increase in motility. So motility is the movement of contents through the digestive tract. And what you can see here is that if the motility speeds up, if you have excessive motility, then instead of it taking 10 or so hours for the contents to make its way through the large intestine, it speeds it up very, very quickly. So again, when the contents move very quickly through the large intestine, it doesn't actually have time to be absorbed into the blood vessels. And so what happens is water stays in there, and then you end up again with an increase in fluid volume, fluid content, and volume of the feces, right? So transit time is basically the amount of time that the contents of the in this case the large intestine spend in the large intestine. So if you increase transit time, it means that it goes slower through the intestine, and you could end up with constipation. But if you decrease that transit time, that means it goes through the large intestine very, very quickly, and you could end up with diarrhea because there's no opportunity for water to be absorbed, and so the water stays in the colon and it whooshes out as diarrhea. second syndrome I'm going to talk about is malabsorption. So again, mal is a negative absorption. And so malabsorption is the failure of the nutrients that we eat to be digested. Now, because 90% of absorption occurs in the small intestine, that's where a lot of malabsorption syndromes are centered on. In order for food that we eat to be absorbed, it needs to be digested first, right? And digestion is the breakdown of the food that we eat, both chemically as well as mechanically, into smaller and simple enough components so that it could enter into the blood vessels associated with the digestive tract, right? And that's what absorption is. So some of the common causes of malabsorption syndromes comes from the fact that our pancreas is the source of enzymes and other pancreatic juices that help to chemically digest the food that we eat, right? And if you look right at the first picture over here, the pancreas is this mass that's right over here that's located just next door to the duodenum, which is the first part of the small intestine, and the duodenum starts just after the pyloric sphincter between the stomach and the small intestine. So, if the pancreas cannot produce and release enough pancreatic juices, which contains enzymes as well as bicarb, then what happens is that chemical digestion decreases, and with chemical digestion decreasing, then what happens is the chyme, the food particles that are broken down, can't be broken down into simple enough particles that we can absorb, right? So this would be, if you look over here, pancreatic enzymes. One of the pancreatic enzymes includes pancreatic amylase that helps to break down carbohydrate. Another one include a few different pancreatic enzymes, including trypsin, chymotrypsin, carboxypeptidase, that are involved in breaking down protein, as well as lipase, that again are involved in breaking down fats, right? So again, if you look at the pancreatic enzymes, they're involved in breaking down 3 of the major food groups that are found in food. Another common cause of malabsorption syndrome is a deficiency in the enzyme lactase. So sometimes we hear of people saying, I'm lactose intolerant. So it's not that they're allergic to lactose, which is a disaccharide. What actually happens with lactose intolerance is commonly the enzyme lactase, ASE, isn't being produced in sufficient quantities. And so if that person eats or drinks something containing lactose, milk products from the cow, then what happens is that lactose remains undigested, and it actually induces osmotic diarrhea, where instead of water being absorbed in the large intestine, it stays within the lumen of the large intestines, and then it leaves the body as diarrhea. So that's lactase deficiency over there. The third common cause is bile salt deficiency. So bile salts are produced by the liver, stored in the gallbladder, and released when there are lipids in the small intestine. And so if bile salts aren't produced and released in sufficient quantities, you end up with bile salt deficiency. And what happens is bile salt is involved in what they call emulsifying lipids. And so emulsification is when the bile salts actually help to break down fat droplets into smaller and smaller components physically, so that the enzyme lipase can actually break it down chemically, right? And again, that happens in the duodenum, the first part of the small intestine. Fourth thing is gluten-sensitive enteropathy. So again, it's sensitivity to gluten that's found in a lot of wheat products, and it causes the intestinal villi to atrophy, to die off. And if you remember, in the small intestine, you've got this villi, which increase the surface area of the small intestine. And with the increase of the surface area of the intestine, what happens is you have these enterocytes, and you have this microvilli. And what happens is that for nutrients to be absorbed, it has to go through the microvilli and the villi, and then what you have is capillaries and lacteals in the villi that basically can absorb that absorbed food can actually enter into. What happens in gluten-sensitive enteropathy is that these villi are destroyed, right? Are atrophied. And so what happens is, instead of this nice increased surface area, it's flat. And when you have a decrease in surface area, then you basically have a decrease in the ability of the small intestine to absorb nutrients. Third common manifestations of digestive disorders is bleeding through the gastrointestinal tract, right? So what happens is, if it's bleeding from if the site of bleeding is within the upper gastrointestinal tract, and by upper gastrointestinal tract, we're meaning the esophagus, the stomach, and the first part of the small intestine, what happens is it will be like vomiting blood, right? So that's what hematemesis is, the vomiting, emesis of blood. If the bleeding is in one of the lower parts of the gastrointestinal tract, so from the jejunum onwards, so that would be the jejunum, the ileum, and the various parts of the large intestine, then what happens is the blood will basically collect itself and leave the digestive tract in the feces. So again, you can have occult blood, which is hidden, right? That's what the word occult is. You can have melena, which is black tarry feces, and then you can have hematochezia, which is bright red blood and feces. And basically, the color of the blood, whether it be in the vomiting or the feces, is an indication of how close to the opening the source of bleeding is, right? If it's really close to the rectal and anal area, it will tend to be bright red. If it's further up in the small intestine, it will tend to be darker, or it can be hidden, right? So let's go through this. So you can have an accumulation of blood in the gastrointestinal tract. And what happens is, when that happens, then you can end up with diarrhea. And these are just the sources of bleeding. So upper GI bleed due from esophageal varices that we'll look at when we look at disorders of accessory glands, accessory organs of the digestive tract. Bleeding ulcers that we're going to look at when we look at peptic ulcer disease. And then we're going to look at some of these other sources later on in this recording. With bleeding, what happens is because the blood leaves the blood vessels, then you have a depletion of blood volume. Again, depending on the volume of blood that's either vomited, or that leaves in fecal matter. Once you have a decrease in blood volume, then it means that the heart has less blood to pump out of it. So it decreases cardiac output, which then leads to a decrease in systolic blood pressure, right? With that, a compensation mechanism is for the heart to start beating faster. So you can see here the pulse rate increases. So you end up with tachycardia. And again, with a decrease in blood, the skin will then look pale. There is less blood going to the kidneys. And so there's a decrease in urine output, which then, if that's sustained over a period of time, may actually end up with renal failure, with either a severe decrease in urine production or the absence of urine being produced. With the decrease in cardiac output, what happens is you can end up with metabolic acidosis. And as you can see here, if it's again severe enough and sustained enough, it could lead to death. And because it's metabolic acidosis, it could then cause lactic acidosis, which end up with anoxia. Now, some of these compensatory mechanisms we've actually covered when we talked about cardiovascular disorders. So again, review the connection between this and again, the connection between a decrease in blood flow to the brain, because you can see that different parts of the body are connected. So over here, we talk about what started off in the gastrointestinal tract, ending up affecting the kidney, ending up affecting the heart, and ending up affecting the brain and blood flow throughout the body. One of the things that I'm going to talk about now here is obstruction of the intestine. So if you have a piece of intestine over here, if there is some blockage somewhere over here, and the contents of the intestine are flowing this way, which is towards the anus, right? What happens is that blockage will prevent flow of the contents of the intestine towards the anus. So you end up with an obstruction over here, and it causes local accumulation, right? So the contents of the intestine just build up over here on the proximal side before the blockage, and there's less movement distal to the blockage. Now, some common causes of intestinal obstruction can be herniation, where part of the intestine basically pouches out through the inguinal canal. So you've got that, and you can imagine that because it pouches out through a small opening, what happens is if the intestinal contents are flowing this way, because it's constricted at this point, it can't really flow easily past the site of herniation. A second reason for intestinal obstruction is adhesions that form, so scarring that forms as a result of abdominal surgery. And if you remember, your small intestines are just interwoven and sort of folded in on each other. And that allows the small intestine to move in place as the contents move through. But with adhesions, what happens is it kind of almost locks it in place. So again, it stops easy passage of the contents through to the site of the obstruction. A volvulus, as you can see over here, is a knot or a twist in the intestinal area. So again, if you have the flow of contents over here, you can imagine that it's severely inhibited by this knot. So again, you end up with local accumulation. And then intussusception is when you have a telescoping of one part of the intestine into the other, usually because of severe dehydration and malnourishment. And so what happens is, again, the contents then are blocked from actually going through. So let's have a look at what happens with intestinal obstruction. So what happens is that you have a local accumulation or a sequestration of gas and fluid and contents proximal to the obstruction. The obstruction, as you can see, is over here. And what happens is it puts pressure on the diaphragm. It can put pressure in the diaphragm, which reduces the ability for expansion and contraction, retraction of the thoracic cavity. So you end up with a decrease in respiratory volume, which might end up with atelectasis. The distension, the accumulation of gas and fluid and contents proximal to the obstruction means that there's very little movement distal to it. And so then that can cause loss of water and electrolytes, right? And if we have a loss of water and electrolytes being absorbed in from the intestine, then you end up with dehydration, hypokalemia, a reduction in potassium absorption, and hypochloremia, right? The same with chlorine. This can also then follow through and end up with ischemia through a reduction in blood flow. And then you could also end up with hypovolemia and then shock. And again, if hypovolemia and shock occurs for a long time, then it could have more severe consequences. The next thing we're going to talk about is hernias and the lower esophageal sphincter. So in this diagram over here, the LES, the lower esophageal sphincter, basically is a circular muscle that is closed most of the time, with the exception of when a bolus of food progresses down from the distal esophagus into the stomach. And then so if peristalsis movement moves this bolus of food into the stomach, then the lower esophageal sphincter opens briefly to allow food to go here. The lower esophageal sphincter is a high pressure zone, again, to stop acidic contents of the stomach from going back up to the esophagus, right? When we look at the normal setting, what happens is the diaphragm is located just above the lower esophageal sphincter. So again, because the diaphragm is located just above the lower esophageal sphincter, the lower esophageal sphincter can actually do its job, right? And keep the stomach, the acid in the stomach and not in the esophagus. However, there are several different scenarios where part of the stomach actually goes above the diaphragm. And when part of the stomach goes above the diaphragm, the LES is not really functional, because what happens is the stomach, as you can see here, is much larger than the tubular esophagus. And so it makes a that point of constriction then actually becomes moves away from the lower esophageal sphincter. So again, what we're going to see here is we're going to see two different hernias and then a mixed hernia, which contains elements of the first two. So the first one is a hiatal hernia, a sliding hiatal hernia, where part of the stomach actually emerges proximal to the diaphragm. So instead of the diaphragm being just above the LES, part of the stomach actually moves up, and it's called a sliding hiatal hernia because what happens is as we breathe in and out, it slides that stomach, that part of the stomach that appears proximal to the diaphragm, slides in and out. And what happens is then the point of constriction happens over here, right? And this part of the stomach is above that point of constriction, and this part of the stomach can freely or more freely push acid that should stay in the stomach into the esophagus. In the paraesophageal hiatal hernia, what you can see here is, again, part of the stomach appears north or proximal to the diaphragm. So again, this part of the stomach produces acid, and then acid is more able to freely move into the esophagus. One of the big things with this is that the esophagus is not set up to withstand gastric acid, right? And then a mixed hernia has elements of both a hiatal hernia as well as a paraesophageal hernia. So, as I said, the esophagus is not designed to withstand the acid from the stomach. And so with this condition called gastroesophageal reflux disease, again, what it is in the name, where part of the stomach contents enter into the esophagus, and it's a reflux because it goes the other way. And what's dangerous is if when acid enters into the esophagus, as well as pepsin. So pepsin is one of the enzymes that digest proteins, right? And muscles are proteins. So progression of GERD goes as this. So there's some reason why either the LES stops working because of a hiatal hernia or a paraesophageal hernia or both, or the LES just stops working properly and it relaxes to allow acid to come up from the stomach into the esophagus. And then what happens is that acid starts causing inflammation, right, in the mucosa of the esophagus. And so when it starts doing that, it's called reflux esophagitis. People who have reflux esophagitis also have what's called heartburn. And postprandial means after a meal, right? So you eat a meal, you sit on the couch, you watch TV, and suddenly you feel this chest pain, which is not related to the heart. So that's why they call it non-cardiac chest pain. If the reflux esophagitis goes on for a long period of time, it can actually cause an ulcer, and we'll look at that more in detail with the next recording. So it can cause ulcers, which is an erosion of the deeper layers of the esophageal layers, and it can cause bleeding as well because there are blood vessels just under the epithelium layer, right? So that's an ulcer over here, and if that happens again for a long period of time, it can cause scar formation. So you can imagine if you have formation of scar tissue over here, it narrows the esophageal opening. And one of the things that the esophagus does in order to protect it from long-term damage from acid is it starts changing to resemble the epithelium of the stomach. And that's when it becomes Barrett's esophagus. And again, once you have Barrett's esophagus, the next step for that is dysplasia and then cancer. So esophageal cancer is something that is one of the most serious effects of gastroesophageal reflux disease, again, due to chronic exposure of the esophageal lining to acid and pepsin. So you've got over here, that's esophageal cancer is squamous cell carcinoma. So that's carcinoma, a cancer of the esophageal epithelium. It's a silent disease because yes, you do feel heartburn and all that, but sometimes there's no other symptoms. It can cause trouble swallowing, dysphagia. And so one of the things that are used to detect esophageal cancer is this barium swallowing X-ray, where a person drinks a liquid that contains barium, and then you can see whether there are strictures or narrowing and cancerous looking cells within the esophagus, right? So you can see over here, there's a difference in the epithelial lining where it has gone from normal esophageal epithelium to Barrett inflammation, reflux esophagitis, to Barrett's esophagus, to dysplasia, and then cancer, right? So the risk factors: men over the age of 65 who smoke, who suffer from alcoholism, and then Barrett's esophagus as being the precursor to esophageal cancer. Next, we're going to go on the other side of the stomach. So in the bowel. So I'm going to talk about two different conditions which kind of look similar, right? So the first one is Crohn's disease. So both these conditions, Crohn's disease and ulcerative colitis, are chronic conditions. Sometimes they have flare-ups, so it's episodic, so it's not constant. And the symptoms are very common to each other. So if you look down in the table over here, I put common symptoms. So again, common symptoms are recurrent, episodic diarrhea, so diarrhea that comes and goes, abdominal pain, and blood in the stools, right? The difference between Crohn's disease and ulcerative colitis is that Crohn's disease, we have what's called skip or segmental lesions. So if you look over here, the affected areas are not continuous. So you've got an affected area here, affected area here, affected area here, affected area here. Versus ulcerative colitis, which is continuous when it starts, and it usually starts in the colorectal area, and as I said, it's continuous. Crohn's disease can appear anywhere from the mouth to the anus, so from the start of the digestive tract to the end of it. Both conditions have got a strong family history component as well as an autoimmune component as well. With Crohn's disease, there is chronic inflammation, again, in various areas of the digestive tract, from the mouth to the anus. And what you can see here is the inflammation goes deep down, right? So it not only affects the mucosa, but also the submucosa and into the muscle layer, right? Ulcerative colitis, on the other hand, is superficial, just in the mucosa. And what you can end up with is the pseudo polyps, right? So it just affects the most superficial layer, the mucosal layer, and you end up with these pseudo polyps. The next condition is called diverticular disease of the colon. So again, it affects the distal part of the colon. And what diverticula are they are outpouchings or herniations of the mucosa and submucosa through the muscle layers. So again, if you look at just a cross section of the layers of the digestive tract, you've got the mucosa over here, you've got the submucosa over here, and then you've got the muscular layer. And what happens in diverticula is that it gets inverted, right? So parts of the mucosa and the submucosa pouches out through the muscle layers in the sigmoid colon. It's common in the elderly and people who eat refined foods and experience severe constipation, because what happens is if you eat refined foods, that's not enough fibers, and when you have very low fiber diet, it reduces the bulk of the fecal material, and it basically shrinks the diameter of the colon, and then you end up with this diverticula. Diverticulosis is basically an asymptomatic version of diverticula, and diverticulitis, again, itis, means that there's inflammation because of the presence of diverticula, right? And what happens is when there's inflammation in the colon, in the distal colon, in the sigmoid colon, what happens is that absorption doesn't occur as much as normal. It can increase the pressure inside of the lumen of the colon, so it causes an increase in intraluminal pressure, and if it increases enough, it can rupture the diverticulitis and cause perforations, cause holes all the way through the different layers of the colon, and cause peritonitis, right? Inflammation of the peritoneal cavity. Appendicitis, just to remind you, the appendix is the organ that's right at the start of the cecum over there. And so appendicitis will lead to referred pain. So this is just a diagram showing you the location of referred pain with appendicitis. Appendicitis is sometimes triggered by a viral infection that then activates the lymphocytes and other immune cells that are in the appendix, and then it causes inflammation, it causes hyperplasia, and then it can cause swelling of the appendix, and cause, if left untreated, it can cause perforation, it can burst, and then the contents of the large intestine then actually enter into the abdominal cavity to cause peritonitis, right? Similar to diverticulitis. Treatment is surgery, obviously, before it ruptures. It's easier before it ruptures so that perforation and peritonitis are avoided. And so that's what it is. Progression of appendicitis, again, location of appendix over here. There's an obstruction at the opening of the appendix, either due to accumulation of stool, tumors, or foreign objects. And then what happens is then the contents of the appendix get infected, and pressure builds up because there's no drainage from the appendix into the cecum. And so the appendix then is distended, blows up, increases in size due to accumulation of gases and mucus. Intraluminal pressure increases. Blood flow to the appendix decreases. Because blood flow to the appendix decreases, you end up with ischemia and hypoxia. And again, if that continues on for longer, it can perforate and then burst, and then you end up with peritonitis, where the contents of the colon then enters into the abdominal cavity and end up with sepsis. Last thing is that the last condition is cancer of the colon and rectal area. So colorectal cancer. And so what you have over here, down here, is just an incidence of where these are commonly found. So 25% in the ascending colon, 15% in the transverse, 5% in the descending, and then 10% in the rectum and colon sigmoid colon area. So colorectal cancer is one of the most common cancers in the world. It starts off as neoplastic polyps, so a growth of the mucosa, and the closer to the proximal part of the colon the cancer is, the later it tends to be diagnosed. And so once it's diagnosed later, you know that the complications increase and the prognosis becomes more serious, right? So you see over here just the different stages of colon cancer. So stage 0 is pretty much normal. Stage 1 is contained within the, it doesn't invade the walls of the colon. Stage 2, it invades the walls of the colon. You can see that there's it goes into the walls. Stage 3, it affects the lymphatic tissue, the lymph node. There's lymph node involvement. And then stage 4 is when it spreads to other organs, commonly the liver and the lung. And on that happy note,